Thank you so much, Marty, and to the Memorial Alumni Society for having me here today, and special congratulations to Carol Agajanian for her magnificent contributions as a medical oncologist, but also as just an absolutely wonderful person. We've already heard a very brief introduction to the biology and pathology of endometrial cancer. This is a summary of the Bachman classification that was originally proposed in 1983, which was based on the epidemiological characteristics of Soviet women in the late 1970s. If that tells you anything about the validity of this model going forward, it should remind you that it has very little applicability to what's going on in the United States at the current time, and if it were up to me, I would ditch this classification entirely. At least in part because there aren't two types of endometrial cancer. From a pathological perspective, there are many different types, and these have already been listed for you by other speakers today, and I will be talking very briefly about each one of them in turn. This is a prototypic example of a FIGO grade 3 endometrioid adenocarcinoma. It's an adenocarcinoma that is typified by solid growth, but by definition must have at least focally recognizable low-grade endometrioid differentiation. Unfortunately, from the perspective of the practicing pathologist, many endometrial cancers that have solid architecture are misinterpreted as grade 3 endometrioid adenocarcinomas solely because they demonstrate solid architecture. Most pathologists ignore the requirement that these tumors show endometrioid differentiation, at least focally. This is a list of recurrent mutations found in endometrioid endometrial carcinomas listed roughly in decreasing order of prevalence, and many of them have immunohistochemical markers associated with them that allow us to recognize these mutational events, in some cases using immunohistochemistry. Next is a depiction of papillary serous carcinoma. As you know, these tumors are high-grade endometrial cancers. They differ in most cases from high-grade endometrioid carcinomas in that they show papillary and micropapillary architecture with diffusely high nuclear grade. The mutational spectrum is smaller than that seen in endometrioid carcinomas. The emphasis here is on recurrent mutations in P53, which we can usually but not always recognize with a P53 immunohistochemical stain. Despite the fact that we used to refer to serous carcinomas as papillary serous carcinomas, we've dropped the term papillary because partly based on work from this institution, we recognize that many serous carcinomas do indeed have a glandular profile. Next are the clear cell carcinomas, a very rare cancer type. These represent probably less than 3% of all endometrial cancers and are much less prevalent, for example, as compared to clear cell carcinomas in the ovary. Clear cell carcinomas have a mutational spectrum that's rather similar to endometrioid adenocarcinomas of the endometrium, and in many cases dissimilar from serous carcinomas, and so we should be very careful about not lumping together all clear cell carcinomas and serous carcinomas of the endometrium and placing them in the same prognostic and therapeutic group. Carcinosarcomas are now classified as carcinomas that have acquired mesenchymal differentiation. It's thought to be as a result of epithelial to mesenchymal transitions that arise in the context of tumor progression from a carcinomatous precursor to a high-grade sarcomatous precursor. A rather recently described tumor, which is still under the radar for most general pathologists, is the dedifferentiated endometrial carcinoma, which in the past had been considered to represent a type of carcinosarcoma. In contrast, in dedifferentiated endometrial carcinoma, the gland-forming components of the tumor are low-grade, whereas in carcinosarcoma they are typically high-grade, and the diffuse areas of the tumor in dedifferentiated endometrial carcinoma are in fact derived from epithelium rather than from mesenchyme. When the undifferentiated or the diffuse component is present in its pure form, we refer to this as an undifferentiated endometrial carcinoma, which sometimes has the appearance of a lymphoma or a high-grade endometrial stromal sarcoma, and in some cases have more of a mesenchymal look. We played around trying to figure out how these tumors had acquired the epithelial mesenchymal transition that is so typical of this tumor entity, and I might add also so typical of carcinosarcomas. And it involves the upregulation of microRNA 200 series, which leads to upregulation of ZEB1 and other related proteins such as snail, and downregulation of E-cadherin, which at least in part accounts for the very disheesive appearance of these cells on microscopy. That is, they don't stick together very well because they've lost their E-cadherin. So what is a very brief summary of the clinical features of high-grade endometrial carcinoma? I would lump together the serous carcinomas with the carcinosarcomas. They have shared risk factors. They arise at approximately the same age, have a similar stage distribution, and more or less similar median survivals, and metastasize to the same sites. In contrast, you have the FIGO grade 3 and clear cell carcinomas, which have arguably subtle, but I think convincingly different profile as compared to these other tumor types. How does this translate into the treatment of endometrial cancer? Well, in 2015, essentially the only time that surgeons and medical oncologists care about the type and the grade of endometrial cancer is in this specific rubric when you have low-stage disease and high-grade carcinoma. In this case, patients are usually treated with chemotherapy, and sometimes the adjuvant approach is titrated to the type and grade of the tumor that is diagnosed. So what I've shown you up to this point are prototypic examples and generalizations about high-grade endometrial cancer, but really the problem and the main reason why I'm presenting this information is that between 30 and 50% of high-grade endometrial carcinomas are not prototypic, and this leads to significant problems in inter-observer variability and accurate diagnosis. And we can tell from a number of different sources that this is an ongoing problem and quite a significant problem. The GOG Pathology Committee performed an audit based on the cases that were accrued under GOG 210. And based on this audit, in which we found problems with reproducible diagnosis of subtypes of high-grade endometrial cancer and 1988 FIGO stages 2 and 3 endometrial cancer, that we re-review all cases that met these criteria, and this constituted 20% of all cases that had been enrolled in GOG 210. There was a Vancouver General Hospital case series in which 3 pathologists, I was one of them, we each considered ourselves gynecologic specialists, looked at a consecutive series of high-grade endometrial carcinomas from the Vancouver General Hospital, and we only agreed on diagnosis 64% of the time. And the problem really concerned the distinction of FIGO grade 3 endometrioid carcinoma and serous carcinoma, and in rarer cases, serous carcinoma from clear cell carcinoma. So the conclusions from the first part of the talk are these. Some high-grade endometrial carcinomas are rather easily diagnosed, and I'm going to tell you in just a minute which ones they are. Many others are not diagnosed reproducibly, and that's because of hypothetically at least, because of a number of different issues here. But there's a fourth that I'm going to talk about subsequently. And this is meant to illustrate a diagnostic problem, a tumor which is rather well differentiated from an architectural standpoint, but shows terrible nuclear features. And in this case, your differential diagnosis is a horrible endometrioid carcinoma or a serous carcinoma with glandular architecture. And tumors such as these were the subject of a study that we performed with a former fellow and then a colleague of ours, Karuna Garg, back in 2010. What we did in this study is looked at, I think there were 35 diagnostically difficult endometrial cancers. We were blinded to outcome and P53 immunohistochemical status. And based just on morphological review, Karuna and I were able to separate the good actors, i.e. the FIGO grade 2 endometrioid carcinomas, and the tumors whose outcome profile was more consistent with low stage but high-grade serous carcinoma. We then performed the same experiment using a number of fellows and attendings from the department, and they were were not able to separate the grade 2 endometrioid carcinomas from the serous carcinomas, with only one exception. And the person who was able to produce a Kaplan-Meier survival curve that looked like this was a fellow who had just finished her gynecologic pathology rotation on our service, which means the pathologists are educable. Now, we have a very similar looking Kaplan-Meier survival curve when we looked only at P53 expression. So this is the first clue in this talk, that P53 overexpression most definitely correlates with P53 mutation and has important prognostic implications in endometrial cancer. There was a follow-up study led actually by this year's gynecologic pathology fellow, Lin Huang. And in this study, a consecutive number of endometrial cancers from Vancouver General Hospital were subjected to genotypic analysis. And the tumors were assigned to either an endometrioid category or a serous category based on the mutational profile. And the other component of this study was that a large number of pathologists independently reviewed slides and in some cases immunohistochemical stains. And so what we were able to learn from this study was whether the pathologists were able to agree with one another on histological diagnosis and when there were phenotype-genotype inconsistencies. The first bullet point here really validates the work that Karuna Garg and I had done, because these are the criteria that we use to separate the grade 2 endometrioid carcinomas and serous carcinomas. Basically, if the tumor has a papillary or glandular pattern and there's diffusely high nuclear grade, for all intents and purposes, with some exceptions that I'm going to cover in just a moment, those are serous carcinomas irrespective of the presence of papillary architecture. What I had always hesitated to study were the high-grade endometrial cancers with a solid pattern, because I thought I would be jumping into a very complicated morass. But what we learned from this study when we performed the genotype-phenotype correlations was that one could make a confident diagnosis of grade 3 endometrioid carcinoma when a low-grade endometrioid component was present, or the types of metaplasia usually seen in endometrioid carcinoma was present, which leads us to the beginning of this kind of algorithm for working up cases. If you have a tumor for which the differential diagnosis is solid serous carcinoma or endometrioid carcinoma, we search carefully for a low-grade endometrioid component or metaplasia. If present, we assign that to the grade 3 endometrioid category. And if not, we look at P53 immunohistochemistry. If there is no aberrant staining, it is likely that that tumor is either a grade 3 endometrioid carcinoma or perhaps a clear cell carcinoma. But if there is aberrant P53 immunohistochemical staining, then our suspicion for serous carcinoma increases. Now, if I had been doing this presentation 5 years ago, this box would have said definitely serous. But since the publication of the TCGA data, and then I'm going to go through in a little bit more detail in just a moment, we now know that there is a small but important percentage of non-serous carcinomas that do have P53 mutation. And this gives you an idea of the distribution of TP53 mutations in a cohort that is composed of endometrioid and serous carcinomas. Not surprisingly, 100% of serous carcinomas do have P50, or nearly 100% have P53 mutations, but that depending upon the genomic subtype of endometrioid adenocarcinomas, rates of P53 mutation range from 4% up to 56%. So conclusions from the second part of this talk are that the tumor genotype and immunophenotype might provide prognostic and predictive information, and at least given the example of the study I did with Karuna Garg, it also helps pathologists to become better diagnosticians. In most cases, we're able to diagnose serous carcinoma without the use of a P53 stain, but only after we've had the experience of correlating our morphological impression with P53 immunohistochemistry over a long period of time. Now, you've seen this slide, I don't know, 3, 4 times already today. That's okay. Sometimes I think a little bit of repetition is good. again, instead of having 2 types of endometrial cancer, we now recognize 4 types of endometrial cancer. The denominator here is endometrioid and serous cancer. This doesn't tell us anything about carcinosarcomas or clear cell carcinomas, for example. If we have time for questions, doubtful that we will. I'd be happy to answer questions about those subtypes. What you've already heard is that the 4 types of genomically defined endometrial cancers are the polymerase E hotspot mutated endometrial cancers, the hypermutated or MSI high endometrial cancers, the copy number low endometrioids, which are very much like the type 1 endometrioid carcinomas of Bachman, and the copy number high or serous-like endometrial cancers, which are very much like the type 2 endometrial cancers described by Bachman. And you've already been introduced to the idea that the number of mutations per cell differ in each group, whether or not there's microsatellite instability affects group assignment, and the copy number high group is defined by the presence of frequent deletions and amplifications. So what I want to cover now is the promiscuity of grade 3 endometrioid adenocarcinomas. If you look at this plot, all the serous carcinomas fall into this category. And all of the light gray tumors here are the endometrioid carcinomas, and the purple tumors are the serous carcinomas, and the dark gray annotation below indicates which tumors are high grade. So this gives you an idea of where the grade 3 endometrioid carcinomas live. A lot of them live in the serous-like category. A lot of them live in the polymerase E hotspot mutated category, and a modest number live in the MSI high category, but very few of them map to the type 1 classical copy number low endometrioid adenocarcinoma. And this has some implications for the diagnostic accuracy. What we found in this study was, which was a retrospective review of slides submitted to the TCGA of patients who were originally diagnosed as having grade 3 endometrioid adenocarcinoma. And then Russell Broadus, my counterpart at Anderson, and I sat down and independently reviewed the slides, with our hypothesis being that none of those endometrioid carcinomas in the serous-like group were actually endometrioid. And in fact, number one, we were wrong, but the other thing that we figured out by accident was that the ability for Russell and me to decide on that a given case was a grade 3 endometrioid very much depended upon the genomic subgroup from which it emerged. So when you're talking about typical type 1 endometrial cancer, Russell and I agreed in every case that the tumor in question was grade 3 endometrioid adenocarcinoma. But when we looked at the CNI high tumors, the MSI high tumors, and the polymutated tumors, our kappas were significantly lower. And these data are going to be published in short order and are actually in the process of being validated by a combined cohort of patients from Vancouver and from New York. So what else is important about these TCGA-defined subgroups? Well, at low power examination, from a forest through the trees kind of perspective, the serous-like signature is prognostically unfavorable, and the poly signature is prognostically highly favorable. But there's a lot more detail regarding this that I want to cover with you. Let's now focus only on the copy number high, or the serous like cluster, again defined by many deletions and amplifications. And what we find here is that 3/4 of the tumors in this group are serous, and 1/4 are high-grade endometrioid. And as I've already told you, these all show high copy number alterations, and almost all show recurrent P53 mutations. How do we translate this into clinical practice? I give you this tumor, a tumor that has solid architecture, which I think by most pathologists would be categorized as grade 3 endometrioid carcinoma because of its architecture, but it has a really high nuclear grade, really high mitotic index, which leaves open the theoretical possibility that this is really a serous carcinoma that happens to have a solid growth pattern. These are the challenges when we look in detail at the CN high group. Are the serous-like grade 3 endometrioid tumors really endometrioid from a genomic perspective and from a morphological perspective? Are serous-like grade 3 endometrioids clinically interchangeable with serous carcinomas? They all have P53 mutation, they all have high copy number alteration. Should we even care whether we're dealing with a grade 3 endometrioid that's CN high or a serous carcinoma? Should P53 be performed on all grade 3 endometrioid carcinomas in attempt to recognize which grade 3 endometrioids belong in the serous-like group? And if the answer is no, is there a better assay than P53? Well, to answer some of these questions, it turns out that some serous-like carcinomas in cluster 4 do have endometrioid type mutations such as PTEN and ARID1A. So at least from a genomic perspective, the answer is yes. There are some genomically endometrioid carcinomas that populate the CN high group. Are there any CN high tumors that actually look like endometrioid adenocarcinomas under the microscope? Take my word for it. Yes, they do. At least Russell and I were able to agree in 7 cases that these tumors were definitely high-grade endometrioid carcinomas, despite the fact that from a genomic perspective, they were serous-like. And this small study that's in the process of going to publication really looked at the question of whether or not we should care about subtyping CN high tumors, whether we should care whether we're dealing with a P53 mutated grade 3 endometrioid carcinoma or a serous carcinoma. And the answer is maybe not. And that's because when we did P53 mutational analysis and P53 immunohistochemistry on about 70 grade 3 endometrioid carcinomas from Memorial, we found that the patients whose tumors had P53 mutations and or showed aberrant P53 expression were much more likely to recur than grade 3 endometrioid carcinomas that lacked P53 mutation. So conclusions from the third part of the talk are that genomic diversity of these grade 3 endometrioid carcinomas, at least in part, accounts for lacking diagnostic concordance, number 1. Are serous-like grade 3 endometrioid carcinomas really endometrioid? Yes, but they're difficult to diagnose reproducibly. Are they clinically interchangeable with serous carcinomas? Maybe. They seem to recur at about the same rates as serous carcinomas, but what I'll tell you is that the sites of metastasis, based on studying only small numbers of patients, seem to be different, with the serous-like grade 3 endometrioid carcinomas metastasizing to nodes and viscera, and the serous carcinomas metastasizing to nodes, viscera, and peritoneum. Next part, should P53 be performed on all grade 3 endometrioids in an attempt to figure out which ones are serous-like? Yes, but we have to be aware that other tumor types also have TP53 mutations, including the polymerase E tumors. And is there a better assay than P53 to put a grade 3 endometrioid in a serous-like category? We don't know. Perhaps it's ploidy, and we have a study in progress that's looking at that. I'm going to now, this is the last part of the talk, I'm going to shift my focus now to the tumors with the poly hotspot mutations. Are these independently associated with favorable outcome, and what is the best assay to help us recognize these tumors? And again, a very familiar plot here indicating that even given the limited numbers of POL-E cases in the TCGA and the rather limited clinical annotation, these did appear to be highly prognostically favorable tumors. We put together our experience with POL-E mutated tumors with that of the Vancouver group, and this was a summary of what we found. These patients tend to be on the young side. They tend not to have highly elevated BMIs. They have a stage distribution that's rather similar to low-grade endometrial carcinoma in general, and despite the fact that a good number of them did receive adjuvant therapy, there were no recurrences with a rather modest median follow-up time. Now, the problem with the POL-E mutated endometrial cancers is that they sometimes look exactly like serous cancers. And here is an example of a POL-E mutated endometrial cancer that looks exactly like a serous cancer. And guess what? It also had a P53 mutation. So from a clinical and pathological perspective, we really run the risk of misdiagnosing a tumor such as this as a serous carcinoma, and then perhaps subjecting them to highly toxic and perhaps ineffective therapy. This is an example of the same POL-E mutated endometrial cancer. Luckily, we did recognize that there was a low-grade endometrioid component associated with us that helped us to validate our suspicion that this was indeed an endometrioid adenocarcinoma with intratumoral heterogeneity. But in many cases, the tumors were monomorphic, and this is an example of a low-grade endometrioid adenocarcinoma from the POL-E group. And what's cool about this, and the reason I'm even taking your time to show you this slide, is that these look a lot like microsatellite unstable endometrial cancers. They have tons and tons of peritumoral lymphocytes and many tumor-infiltrating lymphocytes, which at least opens up another avenue for potential therapy in these patients. So here's a comparison of polymerase E hotspot mutated endometrial cancers with serous cancers, again, because this is the largest clinico-pathological problem we face given the context here. The POLE patients are younger. You know they have a better outcome. When they're serous-like features, they're usually, but not always, found only geographically or focally within the tumor. They almost always have confirmatory endometrioid features in the form of low-grade endometrioid carcinoma. They frequently have peritumoral and infiltrating lymphocytes. 1/3 of them have P53 mutations, but I'll tell you the exons involved in the P53 mutations are different. We can't always pick up that degree of subtlety using an immunohistochemical stain alone. And in contrast to serous carcinomas that have very low rates of P10 and ARID1A mutations, we have very high rates in these EC POL tumors. So conclusions regarding the POLE hotspot mutations, we now know that they are independently associated with favorable outcomes in a number of different studies. They were referenced for you at the bottom of one of my previous slides. What's the best assay to determine POLE hotspot mutations? Well, it's really mutational analysis. Sometimes we like to guess. We have a funny-looking endometrial cancer in a youngish patient, and there are a lot of TILs. We synthesize our histological impression with some clinical data and immunohistochemistry, and we can guess at whether there's a POLE mutation, but this is certainly not a very specific way, certainly not a reproducible way to handle diagnosis. So what we've begun to do is we've learned from the TCGA and from our experience studying the POLE mutated endometrial cancers and have expanded this algorithm as follows. If we have a tumor that has aberrant P53 expression, we favor diagnosis of serous carcinoma but cannot completely exclude a mutated grade 3 endometrioid or P53 mutated clear cell carcinoma, at which point we do these immunohistochemical stains. If there's loss of any one of these, we assign the tumor to the endometrioid or clear cell category, and when stains for these markers are normal, then we diagnose serous carcinoma. But this is exactly the point in the algorithm where a POLE mutational analysis would be most helpful, because this would conclusively distinguish between these two without having to rely on these frequently unpredictable immunohistochemical markers that are in use in only a very small handful of academic institutions across the US. Second to the last slide, I believe. This is really the implementation of our algorithm using a large combined cohort from Vancouver and Memorial Sloan Kettering Cancer Center. We attempted to do what the TCGA did, but with very limited resources. So we took a range of endometrioid and serous carcinomas. They all had POLE hotspot mutational analysis and a very limited number of immunohistochemical stains, and we're able to really replicate the Kaplan-Meier survival curves that we found from the TCGA with outstanding prognosis in the POLE group, disappointing prognosis in the serous and serous-like group, and intermediate prognosis in the other groups. So as we look to the future, I think we have to ask ourselves these questions. Are these data sufficiently robust to support routine P53 immunohistochemistry and DNA mismatch repair immunohistochemistry? I'm about at the point where the answer is yes, but always there are issues regarding financing, and this applies equally to, I think, the importance of doing POLE mutational analysis on our patients' material. And again, if you have questions about carcinosarc and clear cell carcinoma, I can certainly try to answer them. Thank you so much for your attention.